Welcome, everyone. It's my great pleasure to bring you towards our sixth webinar on the Commonwealth Tribute to Life program. It's been absolutely fantastic series of talks. I hope you're really enjoying them. The quality's been world-class, and I think today is going to be absolutely no difference. So I'm Dale Gardiner. I'm the Associate Medical Director for Organ and Tissue Donation in the United Kingdom. But it really, what we want to do is to actually make this a Commonwealth-wide process. So we've got some great speakers. Joining me from the UK is Dr. Alex Manara. He'll be co-chairing. Alex helped to lead the work in 2008 on our code of practice for the diagnosis and confirmation of death, and he's been asked to co-chair a revision of that. So it's great that Alex is here. And we've got two excellent speakers for you today. Before we go into that, just from a bit of housekeeping, feel free, we really want to have a panel discussion. So put your questions and any sort of comments you want to make into the Q&A or send a message to the panel in the chat. But otherwise, we'll get straight on. The session should last an hour. But I've got great pleasure in welcoming Sam Shemie, Professor Sam Shemie from Canada, who works in the Department of Pediatrics at McGill University. He's been a medical advisor in deceased donation to the Canadian Blood Services for many years. But probably most importantly for Sam and our relationship with him is he's an internationally recognized expert and leader on the determination of death. He's led this for many decades now. And we're really honored that Sam, you can give us your time and share your reflections on this topic. So immediately straight over to you, Sam.
Thank you very much, Dale, and thanks for the invitation. I'll just launch that and just confirm that you can see the...
Looks perfect, Sam.
Yeah,
thank you.
Great. Okay, I'll get started. Thanks. It's a pleasure to be here to talk about consensus building and the definition and determination of death. Just a little bit of background. In our country, for many years, our organ donor rate didn't change despite multiple government initiatives to try to address it. And it was really related to a couple of things. One was the structure of healthcare in Canada. It's a misconception that we have a single government-funded healthcare system. In fact, it's a regional, provincial healthcare system with 13 different regions. So it's a lot more complicated. We can't have a national system the way that other countries, such as the United Kingdom, have been able to develop. And the second major issue was kind of healthcare culture within intensive care units. This is kind of a historical perspective on the way things used to be between transplanters who needed organs but didn't take care of dying patients, and intensive care doctors who took care of, who saw their role as life-saving and didn't see their role as responsible for managing death and donation. And I've shown this following slide a few times at talks and kind of reflects the cultural difference. This was a pro-con debate between myself and Malcolm Fisher many years ago at a Toronto critical care meeting. And Malcolm Fisher was one of the iconic leaders of critical care coming out of Australia. And my position was that intensive care units should take responsibility for organ donation. And his rebuttal in the pro-con debate was, it's not our fucking problem. And that really reflected the temperament of intensive care practitioners around this area. And our strategies in Canada over the last 20 years has been engage the ICU and have them own the management of deceased donation and death determination, engage emergency medicine practitioners, partnership with professional organizations, and develop communities of practice. Professionalization of donation services really based on the Spanish model of having ICU, donation-focused ICU clinicians drive things, and national leading practices for the development of guidelines for each step in the donor process. And then we also felt that organ donation couldn't just be seen as a utilitarian arm to transplantation. We really needed to advance the science with research. And I'm going to talk about those leading practices. We've had, over the last 20 years, 21 leading practices for each stage of the donation process that have engaged the community of experts to develop these clinical practice guidelines. a third of them are directly related to defining and determining death. And the reason for that is that over 80% of all transplants arise from dead donors. And so understanding what death is very, very important. And since the engagement of the community with these leading practices and implementation strategies, we've had a significant rise in our donor rate per million population over the last 10 years. Critical factors in developing evidence-based consensus, I'll just read through this list. It has to be collaborative structure and including professional societies and patient partners. If people aren't in the room to develop the guidance, they won't adopt it or and implement it in practice. You have to leverage and develop external thought leaders, not just in your country, but internationally. There has to be committed leadership and project management, process design and facilitation. You have to assemble or create the evidence and have an iterative collaborative decision-making process. And you always have to be focused on implementation with engagement of administrative and frontline clinical leaders. Publication in open access peer-reviewed journal, peer-reviewed publications, and advancing or identifying knowledge gaps to advance a research agenda, to advance the science. We have been very fortunate, and I really, truly and sincerely fortunate to work with such international leaders such as Dale Gardiner and Alex Manara. Although I have to say that if I had seen this picture of them before collaborating with them, I might have had second thoughts. I can't tell if they're intensive care doctors here or they work in a fish market, but we have been very lucky and have had a long-standing collaborative, productive relationship. Dale and I published this kind of concept paper that I'm pretty proud of in terms of understanding the sequence of death within the ICU, where technology is routinely used, and all patients, no matter what your primary disease is or your secondary diseases, die through this kind of sequence. Your brain stops, followed by your breathing stops. If your breathing stops, your heart stops, and the circulation stops. And then if your circulation stops, the brain stops. And this sequence of the pathway to death is common to any patient who ultimately will die. And what we do in critical care routinely is interrupt this pathway in order to save life. And we have very many different interventions that we routinely deploy, whether it's a mechanical breathing machine and an artificial airway, whether it's support of the circulation with cardiovascular supports, whether it is cardiopulmonary resuscitation, extracorporeal life support, or basically a heart-lung machine, whether it is a form of ventricular assist or heart replacement technologies, whether it's an artificial lung or an artificial heart. These are routinely deployed to interrupt the sequence of death in an effort to save life. And what brain death is the unintended consequence of trying to save life. It's pretty easy to tell who is alive and who is dead in this picture. It's not as easy to tell in these two pictures. These are two very high profile, very generated a lot of media attention, both in Canada, the Takesha McKitty case, in the United States, the Jahai McMath case, of families who refused to accept the brain death concept and insisted on prolonged somatic or body support of that brain dead patient for a long time. You can understand why there is difficulty in acceptance and understanding that's out there. The brain death concept was kind of first identified by the French in 1959, called coma dépassé, or a state beyond coma, and was influenced worldwide through the Harvard Ad Hoc Committee report in JAMA in 1968 that defined a new brain-based definition of death. The Harvard Medical School had a 50-year anniversary of the JAMA brain death report. And at that time, it was characterized by Alex Capron, who was one of the fathers of the Universal Determination of Death Act in the United States, who really described brain death as well settled but unresolved. And it's there's a lot of issues with brain death, including variability in practices and concept. That variability is not just between countries, but within countries, and sometimes within different intensive care units within the same city. And then there's conceptual challenges such as, is it whole brain or is it brainstem, such as advocated in the UK. The issue of diagnostic error versus these dramatic reports of reversibility. It's all about diagnostic error. The issue of professional understanding and trust, public understanding and trust, and the academic critique. It's not really death, it's really created to serve transplantation. When people use the word death, they're not talking about the same thing. We all have different kind of concepts of what that word means. And what we really are talking about is death of the person when their brain completely and irreversibly stops functioning. We're not talking about death of the human organism or death of the body and its organs. And still there is, these are two reports that we just published in the last couple of months, kind of review of the public understanding of the definition and determination of death and healthcare professional understanding. And there's still a lot of challenges and misconceptions, well accepted, but still challenging. It doesn't help either. This was part of the World Brain Death Project led by Ariane Lewis, looking at international guidelines for the determination of death or brain death, and again, identifying the persisting and significant variability in practices and understanding. And then you have the issue of, is it really two kinds of death? Is it heart death and then brain death? Or is it one kind of death, all centered in the brain? Again, this is an evolution in terms of people's acceptance and understanding. I'll get to that in a few minutes. We had this collaborative report from the UK, Canada, and Australia, led by Dale, including Alex and Helen Opdam from Australia, really kind of elucidating these different concepts of death, somatic death, circulatory death, neurological death, and again, advocating that all death really is brain-based, based on the irreversible loss of consciousness and brainstem reflexes and the capacity to breathe. This was the first time we tried to kind of initiate international guideline development for the determination of death. Alex Manara was part of this work. It was led by Canadian Blood Services in collaboration with the World Health Organization. And what we tried to really elucidate in this work was the sequence of dying after your heart stops beating, the sequence of dying after your brain stops working, and then the combined sequence of circulatory arrest and brain arrest into a single brain-based definition and determination of death. This work was complicated by some kind of socio-political controversies and didn't go any further at that time, but it's been a highly cited paper. And that led us finally to the World Brain Death Project, which was led by the steering committee, including Jean Sung from from Los Angeles, David Greer from Boston University, myself, Ariane Lewis from New York University, and Sylvia Torrance from Canadian Blood Services. And the aim of this project was to consolidate and summarize the knowledge base surrounding the concept and practice of brain death, with the goal of establishing international professional consensus regarding underlying principles and practice. And it was really to serve as a framework for understanding the current model of brain death, to assist countries to further their consolidation and harmonization of brain death practices, and to guide future developments in the field. And this was published in JAMA 2 years ago. The work was endorsed by 5 world federations, including adult and pediatric critical care nursing, neurology, neurosurgery, and neurocritical care world federations, and 27 international organizations representing professional societies related to intensive care or neurointensive care. Within that paper, there are links to many other background work that was conducted, including all these topics. And I would urge you to go to that JAMA paper, and if you want to have a comprehensive overview of all things related to brain death, from practice, confirmatory testing, ECMO, temperature management, documentation, religion, law, and future research, I would urge you to go look at that. It's kind of hidden within the documents, but there's hyperlinks there. The strengths of the World Brain Death Project was an unprecedented and broad international collaboration of highly regarded content experts in the field. It was a high impact publication with international and world society endorsement. The weaknesses, though, were that the work was completely unfunded. And because of the weak evidence base of science in the area of brain death and studying death, there was variable approach to systematic reviews and no formal grading of evidence. There was no patient partnership and no formal ethics representation. The decision-making was generally centralized to the steering committee, but relied on the chapter leads of each of the pieces of work, and it was focused solely on brain death, not death after the arrest of circulation. And when you talk about guiding clinical practice, there's various terms that people use in the literature. Is it a leading practice? Is it recommendations for practice? Is it expert consensus? Is it evidence informed? Is it evidence based? And increasingly, there is increasing demand on rigor and methodology for clinical practice guideline development. And the current clinical practice guideline development methodologies demand increased transparency and rigor, using the AGREE tool and the grading process that has clear definitions of scope, stakeholders, including patient input, rigors of evidence selection and evaluation and editorial independence, and grading of systematic reviews of literature. This is really a single slide showing the grade and AGREE process that's very complicated, and I'm not going to go into it, but it's very onerous. It takes a lot of time and resources to do. But certainly in our country, you can't publish a clinical practice guideline without undergoing this type of methodology. And this has led for us to evolve from the basis of the World Brain Death Project to collaborate with our Canadian Critical Care Society and the Canadian Medical Association. And we are refreshing our brain death guidelines and evolving towards a single brain-based definition of death rather than heart versus brain. We are evolving towards a single brain-based definition and its criteria for the determination after arrest of brain or circulatory function. This work is a comprehensive, it's been 18 months now. We're in the final phases. Alex Manara has served as our international advisor on the work, and Dale Gardiner is one of the editors for a special edition coming up in the Canadian Journal of Anesthesia, which will have somewhere around 20 to 30 manuscripts in support of the guideline. Regardless of whether you believe in your country, whether death is heart-based or brain-based or a single brain-based determination based on a primary brain injury or secondary to a circulatory arrest, this is the problem in our field currently, that consensus, when you use the word consensus, it really means that you don't know. Because from a scientific perspective, if you knew, you wouldn't need consensus. I remember Dale Gardiner saying this to me at a meeting in Beijing a number of years ago, that we are not discoverers, we are explorers. And in order to develop the scientific base for death, defining and determining death, we really have to study it in a prospective way and kind of clarify the areas of variability, uncertainty, and consolidate the science. We used to believe that it was really hard to study death and dying in intensive care units. I think that's no longer true. This is a study led by Sunny Denani at University of Ottawa that looked at over 600 patients in Canada, the Netherlands, and the United Kingdom to characterize the dying process in the ICU after withdrawal of life-sustaining treatment and the deteriorating respiratory and circulatory function leading to death, and published in the New England Journal of Medicine in 2021, really characterizing the dying process in ICU patients as related to donation after cardiac death. In addition, Michael Chasse is one of our leaders here in Canada in ancillary testing, or the testing of brain blood flow in support of brain death. And he has just completed a prospective, blinded, randomized study looking at CT perfusion prior to brain death, during brain death, and after brain death in Canada in over 300 patients. And that study has been completed and will be published soon, looking at CT perfusion that is really kind of the analogy would be the video version, a time-related video version of a CT angiography. In addition, we have a research group out of London, Ontario, led by Tennille Gofton and Murat Slesarav that is really investigating the relationship between the arresting circulation and brain function, looking at multimodal neurophysiological monitoring during the dying process with the deteriorating and then arresting circulation to clarify the relationship between a depleting and arresting circulation and its impact on the arrest of brain function. These studies are feasible and important to do to really clarify the science. In terms of my last slide, I'll just end with, in our pandemic-related Zoom meetings, you really miss the assembly of people together, and sometimes simply getting together over a beer in a pub after a meeting can lead to really an organic and creative advance in understanding its concept. This was after a NHSBT meeting in Harrowsmith a couple of years ago, where we met for a beer after the meeting just to talk about the issue of normothermic regional perfusion, which is effectively donor ECMO, and how to make sure that the brain still had a permanent arrest of circulation and function that led to this publication. Just the kind of organic nature of being together and sharing views. So I'll just end there and happy to answer any questions, and thank you for your attendance and time.
Fantastic, Sam. And I think it's important, I think, to recognize your own leadership in this and actually to give credit to you and your Canadian colleagues and the Canadian Blood Service, because as a unifying force for the world, I mean, I think Canada is heads and shoulders among anywhere else. So just to really pay credit to your own efforts on this topic, and we can see that fruit of that labor and the scientific proof of that you've achieved in that is just incredible. So thank you. We'll go straight on. We're going to welcome David Thomson. He's works at in Cape Town in Groote Schuur Hospital. He's an intensive care doctor, and really, I think it's what we're going to hear is how David took some of that work that sort of Sam had led and took us through and made it work for South Africa in a very practical way, and took sort of that background. We'll go straight over to you, David, and then please feel free to put your questions. We've got a few coming through into the chat for have an interesting panel discussion. And I've got a few questions, but if you don't just want to hear from me, put your own questions into the chat. Over to you, David.
Cool. Thanks very much, Dal, for the invitation to speak. And yeah, these webinars have been great. I advise everyone to really delve into the whole sequence of them. So my talk is on death determination. Human mortality, despite all our advances, still sits at around about 100%. And we have advanced the science, as Sam has been doing great work for, and there's no need for bells or whistles at the moment to fit our coffins with these safeguards, because we can accurately determine death, be it by circulatory or neurological criteria. I've got no financial disclosures. I do need to disclose that I was a transplant surgeon first, and still do practice that, and I alternate between being a transplant surgeon and intensivist. So I can wear both hats at some points. This is our hospital. It's a government-funded hospital in South Africa, just to give you further context. And we transplant heart, lungs, liver, and kidneys. And this is the iconic image that happened in 1967 with the first heart transplant. And the ad hoc Harvard Medical School definition of irreversible coma was highlighted, and that was published a year after the transplant. But it's important to realize that after the polio epidemic, that was when we realized we were able to maintain patients without a sense of person anymore. And the definition actually came up in 1959 from the French. Manara came up with that at the start. And people started to realize it was a problem. How do you go about defining death and changing culture? It's interesting that you can do it in various ways. And you can do it through legislation, and this is the way that the Americans did it, and they passed an act in 1981. But it's just important to realize that if you're wanting to affect change, there's different levels that you can go at as a professional, medical professional. And you've got legislation, which is a long, slow, involved process involving a parliament. You've got regulations, which your Department of Health could publish, and you've got professional guidelines. And you'll see that I'll come round to it, but we opted to go for the professional guideline route to start as the easiest place to build consensus and best practice. And it's been interesting to see around the world as different societies have tried to champion
brain death and promulgated, how those criteria have varied. And I always highlight the role of EEG, which is 70% sensitive and specific. And it's legislated in quite a few jurisdictions. You have to do an EEG for brain death. And I definitely wouldn't want my death determination to be 70% chance of being accurate. And even within various places, there is lots of variability in how we do it. So I think we do really need to look at our professional guidelines and how we're educating and training people to ensure that we do have rigor in our death determination. And despite all this variability, I really want to highlight that no one has ever recovered from being correctly clinically certified dead. So where was the South African situation? We actually have no national guidelines, or had no national guidelines. We had one set of proposed regulations that was never implemented. And we had a National Health Act that did define brain death as death, okay? So brain death is death, is included in the Act. And it stipulated in the case of organ donation that 2 doctors must certify death, one with more than 5 years experience. And therefore that leads death determination to be held to accepted medical standards, as you would be in your normal clinical practice, that you wouldn't be negligent if you're doing it in terms of what the community of practice is. So we aim to get a publication into the South African Medical Journal in terms of death determination. And we led this through the Critical Care Society. And it was piggybacked on the World Brain Death Project, which is an absolute treasure trove of the latest reviews of all things related to brain death and death by neurological criteria. And we reference this document very heavily and actually started working on ours when the draft of this was circulated. And we opted not to use just brain death. And I do think Sam's alluded to this coming together. And we opted to entitle our document Death Determination, because brain death is actually, depending on how good your access is to ICU, under 1% of death. So we opted to include circulatory death in our death determination guidelines. But again, this suffers from another problem of variability in terms of how people are doing it and numerous sets of guidelines. And you would think it's relatively easy. We've got all these special devices that we can use. And it's just a question of switching off the electricity, and then the heart would stop and everyone's going to be completely happy. But precisely how long do you wait? That varies around the world. The Italians are 20 minutes. And I'm not quite sure the Germans are just too long in order to be able to certify someone in time for donation after circulatory death. And what do you actually start counting from? Do you count it from the absence of respiration, movement, auscultation of the heartbeat, palpation of the heartbeat, the ECG flatline? So we needed a process to settle this as well. So we followed the AGREE guidelines, and this is what the reviewers of the journals are using to assess any submission. I didn't do it as rigorously, or we didn't do it as rigorously as the Canadians have done. And I'll allude to how our process went and how we tried to buy in a community of practice as we went along. So there are various domains in terms of the AGREE criteria, but you need to specify your objectives, your questions, and your target population. And there is other domains where you're going to get graded. And we included specific sentences to try and answer all the questions in these domains that the reviewers are going to hold your guidelines accountable to. So we wanted to provide the guidelines covering the process and key questions that arise for medical professionals when they're called upon to determine death in South Africa. And we aim to summarize the current evidence and provide the consensus-based recommendations. So we go through it, we identify various areas where there are definite questions, and our target population is probably twofold: the healthcare workers, and through setting that standard to the patients, their families, and the public. But we were flagged by the reviewers for where was our patient participation. Always difficult to include dead patients in your patient participation group. But you do need community engagement with these guidelines, because death exists at an intersection of medical science and where culture and spirituality do take over. It's important that your panel doesn't exist of just 12 angry men arguing in a single room. This is a very powerful movie. But we had our panel of experts, and we ended up being 18 of us from the Critical Care Society, which in South Africa, you have to have a baseline speciality of surgery, obstetrics, anesthesia. We included allied health, and we included the ethics experts in this group as well. And I think it's important to realize that your panel of experts needs to be suitably qualified. across multiple disciplines. They need to be in leadership positions. They need to include a broad range. For us, it's the public and private sector, allied health, nursing, and also the clinicians. And for South Africa, it must be racially diverse and religiously diverse as well. So you really want to try and tick a lot of boxes with your expert panel. You don't want to start with too few people. So our opening statement is death is a medical occurrence with a social, legal, religious, and cultural consequences requiring common clinical standards for its diagnosis and legal regulation. Stylistically, we went for non-American spelling. And I think it's quite important to realize, and this is a cartoon from XKCD that's online, that whenever you try and develop new guidelines, you're always going to solve the problem that essentially you're just creating one extra. So you really do want to go through the process and try and keep it as aligned as possible. And if someone had already written a sentence that was perfect, there's no need to let a professor fiddle with the preposition position in the statement. And we actually try to keep statements very closely aligned to the other literature and guidelines that exist. We did opt for brain death and neurological determination of death as our preferred terminology. And we debated the terminology terms, and you need to start with your list of definitions. The creation of the statements was done by a steering committee related to the current principles and practice regarding death certification. And we used 2 rounds of a modified electronic Delphi using SurveyMonkey, and I'll take you through that in the next couple of slides. And we've asked the reviewers or the expert panel to rate it on a 9-point Likert scale. We had one face-to-face meeting, which actually ended up just reviewing all the statements in their entirety and presenting the Delphi results as a way to actually tick up success stories rather than just automatically jumping to somewhere where you haven't got agreement. And that was a good way to build momentum during a single day meeting. Consensus was deemed to be achieved if 70% felt the statement is critically important and less than 15% of people feel that the statement is not important. And there are scoring systems you can use. So the process was really easy, and it actually took us 1 week, and I think you don't need too long a time period, and we ran the second round a week afterwards, so everything was still fresh. We would have a question. You could see where people rated it on the Likert scale. And then this question would score 88%, no one objecting, and the statement was going to get included. We ended up with 125 statements, agreement ultimately on 124, and I'll come to the one place where we said we didn't achieve consensus. We used suggested and recommended as the grading system that we used. This was flagged by a reviewer because everyone likes grade 1C, part 2, type level grading, but that unfortunately doesn't exist. And we opted to be quite clear and forceful in our recommendations to not imply doubt where we feel that the medical practice is settled. We underwent a legal review to just check everything was legally compliant. And then we actually hosted it on our Critical Care Society website for the membership, the broader membership, to comment on it. And on the journal submission, the final draft was actually circulated to other professional societies for endorsement. And feedback from those societies was actually just added to the document. And during the feedback from the journal reviewers, when you're making those changes for the journal reviewers, we added the few tweaks that the professional societies recommended. And these were really minor because the document was of a high quality and well reasoned out. So if you've got the evidence and you can refer to really definitive documents like the World Brain Death Project and those JAMA supplementary papers, it really helps to settle the debate. So we go through difficult clinical situations. ECMO is a novel therapy. That was quite easy to get consensus from all the old professors in the group. MRI and CT scan, everyone wants a definitive ancillary test. And I see one of the questions has already come up in the chat about that, but the evidence is just not quite there yet for these to be standalone tests. And there is a practicality in Africa, transcranial Doppler, which although it's a validated test for brain death, the expertise doesn't exist. And the Radiological Society confirmed that. And even though we say that it is an acceptable test, we have to add a qualifier for our local situation. And that's why it's important to have local guidelines, because you want things to be applicable. You don't want a textbook referring to a drug that you never have access to, and then forever hearing presentations about this drug that'll sort out the blood pressure, but you actually don't have access to it. EEG, we managed to steer people away from in the guidelines. And it's really important, and this slide doesn't let me move unless it says there's a real focus on clinical determination. And that comes through from the JAMA paper as well. You need a minimum standard, and you need rigor in how you apply that standard. And for me, that does boil down to your checklists and how you are documenting it and how thoroughly you're going through this. So we came up with our checklists, and we came up with advice sheets to go with those. And those cover things like the preconditions prior to testing, and our checklists give a place for the two doctors to complete it. And we can see whether we meet the requirements. Is the cause known? Is the temperature appropriate? Has the patient been resuscitated? Have you excluded the drug effects? Have you excluded severe metabolic endocrine abnormalities? Are you able to perform an apnea test? And then we had to go to the UK Code of Practice to find where we felt that this was written the best in terms of excluding drug effects and how would we actually guide the clinicians. The one area where we didn't get consensus, and it's funny that it's the time period because we probably had to move on because we were just debating this too long on the day meeting. But consensus was not achieved on a standardized observation period prior to brain death testing. And the observation period was felt to be specific to each individual case. So we actually just struggled to write down on paper one absolutely applicable time period. And because it does vary. If someone comes in with a transhemispheric gunshot, intubated by the side of the road, do you really need to wait an extra 12 hours before you certify that patient brain dead? So those kind of considerations came up for us. But we aligned the document with the World Brain Death Project in terms of anoxic brain injury, therapeutic hypothermia, and in pediatrics, we highlighted that a cautious approach is advised. The testing process, you do need to be able to perform the brainstem reflexes. That includes the apnea testing. And again, it can be a checklist that you follow down. You can add a higher burden to your checklist in terms of writing down what was the blood gas specifically, what were the thresholds. We opted for a tick sheet, and the blood gas is typically printed out and included in the documentation. Doll's eye was excluded. It still gets taught a lot, but it's a submaximal stimulus. We don't include the atropine test in our guidelines, and we have an advice sheet on precisely how you should be doing the testing, and what to do if there's what's compatible with brain death and what isn't compatible with brain death. We also have a whole separate advice sheet on the apnea test. We settled on using a T-piece in our guidelines for practicalities because when it gets down to pediatric determination of death, the size of the suction catheter used to determine the oxygen could potentially occlude the ET tube. So we opted to increase recommendations like this on a pragmatic front and on a simplification front. And then our checklist include the registration number of the doctors doing the certification in order to ensure that it's legally compliant. And we insist on 2 doctors, and we didn't insist on a double standard. And you may be able to refer back to the legal system in South Africa that we only need to have 2 doctors in the case of organ donor, but we didn't want to have to then call in a second doctor in cases of organ donation, but you don't actually know whether they're potential organ donors or would consent or have made an approach before you've certified them dead. So we actually insist on 2 doctors to perform the testing in all cases of brain death. For circulatory death, we left it as 1 doctor, but it does have to have a second confirmatory doctor in circulatory death. Pediatrics, we managed to align ourselves that there doesn't need to be a double standard between pediatrics and adults. In pregnancy, this is where the World Brain Death Project needs to be broad in terms of being applicable across multiple legal jurisdictions. In South Africa, you only achieve legal status when you're delivered, when you are born. So the fetus actually doesn't have any rights in South Africa. So we had to word ours differently because in settings of the decision to support a brain dead pregnant patient and all the considerations related to that. We do go into dealing with a grieving family as well, as does the World Brain Death Project in terms of accommodation and giving families time. In our setting, given the resource constraints, this was set at 24 hours. And then we do consider the organ donation to be standard of end-of-life care and consideration of that to be good practice. And I'm a firm believer, as I think Dale and Sam are, that consent is linked to how we communicate and compassionately handle end-of-life care with the family. And that's not the job of the transplant surgeons. That's the job of the intensivists and the ED doctors who are dealing in these highly stressful situations. and they need to be empowered to own that process and to follow through it as a marker of the quality of care that they're given. A family will always have just lost a loved one. In terms of circulatory death, I think it's important, it's not just the timing, it's the context, okay? So one of the following criteria must be met is what we specified. And this links back, and the reference document for this process was the World Health Organization document that Sam also mentioned. And all this work really builds on previous work by people trying to build consensus. It's inappropriate in the setting where it's inappropriate to attempt CPR, where CPR has failed or treatment aimed at sustaining life has been withdrawn, and treatment may be withdrawn because it's decided to be of no further benefit to the patient and not in his or her best interests or in respect of the patient's wishes. How and for how long? Patient should be observed by the person responsible for confirming death for a minimum period of 5 minutes for us to establish that irreversible circulatory arrest has occurred. And the absence of mechanical cardiac function should be confirmed using a combination of absence of central pulse or absence of heart sounds. If you have invasive monitoring, echo or intra-arterial pressure, then you would use that. You're not using the ECG trace, just so everyone's aware, that can keep flickering for up to 30 minutes, even 45 minutes after a complete loss of cardiac output. And you're going to observe the patient for that whole 5-minute period for continued circulatory arrest. And you would double check that there's no capillary response or any motor response to supraorbital pressure at the end of that time period. And then that's when we decided to specify the time of death. Again, we have a checklist for this in terms of the prerequisites being met, that it's inappropriate to do CPR, that you have checked that it's absent, that you observed the patient for 5 minutes, and that you did those final checks of the papillary in a response to pain, and you certify the time of death. I think it's really important to have documentation standards that you specify in your guidelines, because you need to hold people accountable to this. This is where the legal things come back to you. And then I really do think we have to do training and specifying the specifics of the timing. If you filled in a brain death, then you can fill in the post-mortem request form at that time. It doesn't need to be done by the transplant surgeons after the organs have been recovered. That's very confusing to people. And we really do need to train people in this in order to improve the rigor. Thank you very much, everyone. Happy to take questions.
Absolutely brilliant. I'll let you just close that down. And David and Alex, if you put your camera back on, that'd be fantastic. Well, I just think we've just been blessed by a huge masterclass there. Very much Sam sort of gave us that sort of background, and I really enjoyed, David, hearing how you actually put all that sort of World Brain Death Project, many things that Sam had actually been working on for many years, into practicality, but also the fact that it's not a simple matter of cutting and pasting. You actually still need to build that consensus within your own nation. I think there's something really powerful for that, of what we all need to do, that there's these great international documents we can draw upon, but we still have to go through that detailed process and stakeholder involvement to really make it work. And I do like some of your forms. They look really, really nifty. But I'll just go across to Alex, maybe lead us on some of the questions. And if you've got any more questions, please put them into the chat or the Q&A. Do you want to ask the first question, Alex, or make any comments as well?
Yeah, sure. So the first one is, could clinical testing be replaced by ancillary tests if a family do not accept the concept of brain death to the clinical diagnosis? In other words, could ancillary testing replace the tests? Just a brief comment is that, when the tests are done properly, following all the preconditions, they are pretty much 100% sensitive and specific, whereas not all ancillary tests are. So doing one without the other is probably flawed, in my opinion. But I think Sam would have more details on this because of the studies that he was alluding to in his presentation. Would you be able to comment, Sam?
Sure. I'm just gonna show you a couple of, if I can share screen again, I'll just can you see my slide deck there?
Yes.
Yeah. Sorry, just give me 1 second. We wish this was true. That we wish that this was simple, that brain death equals no function, and no function always equals no flow. but it's not always true. It's generally true, but not always true. And this is one of the problems. And this is why most countries and the World Brain Death Project still settled on a clinical determination and the use of supportive testing only when a fully completed, unconfounded clinical assessment can't be made. And the analogy would be, you can have complete irreversible anuric renal failure, no function, but you can still have renal blood flow. To what degree, it's unclear. And one of the, when we did the systematic review of the sensitivities and specificities of various brain blood flow tests, they're somewhere around between 75% and the low 90s. And we have a lot of choices of types of tests, and none of them are 100% reliable. And we can't distinguish between passive filling, detectable flow, tissue, perfusion, and function. And I would urge you to look at this paper that was led by Michael Chasse and talks about the distinction between flow, perfusion, and function. When we talk about function, we're talking about a living flower. When we talk about flow, we're talking about, is there water in the hose? And we talk about perfusion, which is delivery of that water to the flower. Is the water reaching the plant? And it is true that no flow means no perfusion and no function, but you can have no function and still have perfusion. You can have no function and some perfusion and with flow. So this is the disconnect between the flow and function issue around the way we test for things. And so the simple answer is, this is why brain death determination is a clinical determination, principally supplemented by tests of brain blood flow that we acknowledge don't have the sensitivity and specificity that we want. And the detection of irrelevant flow is difficult to decipher from the detection of relevant flow that leads to perfusion, that leads to function. So a long-winded answer, but there we are.
Excellent, Sam. That's very, very good. I love that picture of the flower and the difference between flow, perfusion, and function. I think is really the key. We just don't have that simple test. That's the binary. And the work I've done on CT angio has also highlighted that neuroradiologists have to interpret it. It's not a computer that says flow or no flow. They actually flow to where, how much pressure was in what time has occurred. It's not a binary flow, no flow, even for the neuroradiologists. They have to interpret it much as we might interpret, does that patient have a ventilator-associated pneumonia? A bit of this and a bit of that and a bit of that adds up to yes. So it's not as we may have thought. I'll ask the next question. Alex and I are taking turns. Yash Javari from India asked, the biggest hurdle in utilization of brain death criteria for organ donation only, unless we uncouple this and use brain death criteria also able to declare clinical death, we are doing the service for our patients, adding pain to death. I'll go to David first, but just for in the UK, we do decouple and we will diagnose the death, determine the death regardless of organ donation. And we teach that very strongly and we have evidence that's exactly what happens. What's the situation for you, David, and then to Sam?
I think they do need to be decoupled because it's part of your end-of-life care. So if you're having a discussion with the family and you have the opportunity to approach them with the certainty that brain death diagnosis gives you, then that lets you have a different type of discussion in that end-of-life care situation. There's a definite overlap when you're getting to the stage of palliation and withdrawal of non-beneficial treatments. But again, that's another area where you need to decouple it from any discussion related to organ donation, because you're not going to get trust in your system if you link the two. So I do think that organ donation is a reflection of good end-of-life care, which includes, certification by brain death or by circulatory death. But they must be decoupled. Yeah.
Sam?
Yeah, I agree with what David said and what you've said, Dale. There is almost a mythological attachment to the heart as the basis of life, if you think about it. And I think increasingly we're moving or trying to evolve away from that in recognition of the increasing ability to replace or support circulation and heart function, but the inability to replace or support brain function. And it really is brain function that determines what we are and who we are. And so that's one of the reasons we're trying to advocate that, and not minimizing at all the challenge of moving society away from a heart-centered concept of death to a brain and consciousness-centered concept of death. And so that's one of the ways we're dealing with it. But I totally agree with you. In and of itself, if somebody looks brain dead, they should be diagnosed as brain dead, because regardless of organ donation, that is one clear. It helps family reconcile a firm line between life and death, and not put the weight of a decision of stopping treatment in a non-brain dead patient on the family's shoulders. It's a legal definition, and that removes the discretionary decision-making that families have to go through during end-of-life care. So fully agree.
Alex, over to you.
Yeah, I'll just put one other thing into there, is that the diagnosis of brain death in countries that support it is generally supported within the legal systems, within the courts. And also, unless you test routinely, then you are not going to be taking up all the training opportunities for teaching your trainees as to how to diagnose brain death. Within the UK, we do about 1,700 brain stem tests every year. And that means 3,400 tests generally, with a number of about 2,400 registered consultants in intensive care, which means that most consultants aren't doing it more than once a year, unless you're working with the neuro centers. And there are obviously people not registered with FICM who are also doing them. So if we're going to teach the next generation, then we need to take every opportunity for training purposes as well. Move on to the next question, I think it's an important one and possibly a difficult one. It's how do we convince families that clinical testing for brain death is in effect equivalent to death, particularly when they're seeing a body that is warm with a heart beating and perfused. I think one comment I would like to make about that is that there are obviously lots of different cultural, religious sensitivities about this, and the acceptance of brain death is going to vary amongst those different cultures, religions, and spiritual beliefs. But one thing that I think certainly I've noticed, and I suspect many practicing would have also noticed, is that families do generally accept it. And when you go in and talk to a family about someone who you've confirmed as being brain dead, many of them will actually spontaneously tell you, yes, I felt this. We felt he's left the room already, or she's left the room already. Now, I know that's bordering into the metaphysical, but it suggests to me that there are a lot of people who can disconnect the presence of a body with a beating heart from the presence of the person itself. I don't know what other panelists would feel about that. Dale?
Yes, I've always been amazed how more often families accept more than they ever don't. And I think part of it is you've got to start with your own staff, yourself, your colleagues, your nurses, because if you don't accept it, why would you expect them to accept it? But when you generally, I find families far more pragmatic even than the doctors and nurses. But David and then Sam?
Yeah, I would just say I think that the technique is time. I think you have to understand that there's never one discussion with a family, and it's not just seeing them brain death testing at that point in time. It's setting the scene for that. It's giving the family time. They're going to be in various stages of the grieving process. But ultimately, most families do come around if you have the opportunity to give them time. I think we as clinicians try and do it too quickly with a little bit too close-ended questions, and that's where you can end up with conflict. So really opening it to let the family express where they are in the process, and it's actually it's more a communication skill that needs to be taught in that setting, rather than actually a debate around the science. And just that probably links back to the first question, like when would we consider doing an ancillary test? If someone had like spinal reflexes that were distressing the staff and the family, that's an indication for me to add an extra layer of test. It's not medically potentially needed, but it really does settle the staff who may be nervous or about a certain reaction, and it can help persuade a family, or at least assist the family. It also adds that element of time to the process as well.
Before we go to Sam, David, it's routine in the UK now for families to observe the clinical testing, usually the second one. What's the situation in South Africa?
So we opted that we can have the two doctors do the testing together. So we're ideally trying to do just the one single apnea test. We have not managed to get beyond, letting families witness CPR. It can happen, and if it happens organically, it's not something we're pursuing. I'm not sure, has it helped families come to terms with that? I think those families are already quite on board, so I'm not sure that it convinces people, but yeah, this is, there's so many areas of this where Sam said we need the science to support it. I'd be more than willing to change my practice, but I run into resistance from multiple sources if you were to try to bring the family in from there. Yeah.
Sam, your thoughts?
Yeah, look, if you look at, brain death is not as controversial as it appears in the media. The legal objections to brain death are extremely rare, and they have a few things in common. One is they're in ultra-Orthodox segments. They're almost exclusively parents of children, either parents of pediatric age children or parents of adult children exclusively. And it brings to question of, are they objecting to brain death, or are they objecting to the loss of their child? And the other area that is clear is that if, we are engaging with Takesha McKitty's family, our very media covered case of objection to brain death. And what they told us was, look, our daughter died suddenly. We felt we were rushed through this. The doctor told us we're going to stop the machine. We weren't ready. And David's absolutely right. We can't pressure families during the worst time of their life. We have to take the time to compassionately communicate, give them the time to reconcile what's happened. If you sense there is resistance, either philosophical, personal, or religious, it definitely helps to bring the family in to watch all elements of the brain death test. And the look on their faces when they watch the apnea test is very clear. And then if that doesn't help reconcile the issue, I agree with David. We get a brain blood flow picture, because showing no circulation to the brain is also very compelling. And so we have been able to, with that, give the families time, compassionate communication. If there's a sense that there's going to be a potential for conflict, bring them into the room to watch the testing and do a brain blood flow scan. I think that goes a long way to preventing and managing any potential for conflict.
Excellent. Yeah, I think that's very interesting with the families. That's been our sort of observation, how powerful it is for them to see you go through the process. But we also, some of our clinicians in the UK worry about distraction with the family during that pivotal testing, in which case we generally teach, will do for us would be a third test, get them back for another one afterwards. It doesn't have to be part of the official one. It could, you just do it again with them, and as a way of, if that's a concern. We're nearly out of time, so I just want to pick up just Sunil Shroff's questions there, which is the views on one test or two tests for brain death determination, and replaceability of the apnea test. If you couldn't do the apnea test, would you be happy with an ancillary test? We're going to potentially Sam first here.
Yeah, when you look at cases of discrepancy between the first exam and the second exam, it's usually because the first exam was done by an inexperienced clinician that didn't fulfill prerequisites and eliminate confounders. So training and experience are important. We in Canada advocate a single exam. Our laws say for the purposes of donation, you need to have two physicians. So we encourage two physicians watching the the same examination. In terms of the apnea test, that is, to me, the most important element of the clinical examination, and it's reserved as the last clinical test. There are ways to mitigate any instability during the apnea test, including CO2 insufflation, for instance, to shorten the duration of time, maintaining CPAP during the apnea test, etc. So there's ways to mitigate that, but if you can't do the apnea test, for us, that's an indication to do a mandatory reason to do an ancillary test to demonstrate the absence of brain blood flow.
David, any comment? And then maybe we'll finish the session with leaving Alex have the last word.
I would agree. I mean, I think it comes down to the rigor of your testing and how many safeguards you want to put into that. So having a second doctor, I think, establishes a layer of trust in the process. But you know, technically, if the one doctor does it correctly, then it is still an absolute certification of the finality of the situation. But I think it's more how do you put the systems in place to reliably do it? And there can be differences between doctors, and it is linked to inexperience. I think adding that extra layer, Alex already alluded to, you know, this isn't a frequent event, even for intensivists. So you can double it. So there's 2 doctors, you know, involved in each one. So I would be in favor of 2. Especially in where there's a lot of pushback from families. It's nice to have that second opinion. I think that the families appreciate it.
Excellent. Well, that's been fantastic from my point of view, from just a world-class sort of speakers, and really sort of taking this project and this topic forward. Alex, final words from you, and then we'll close out the session.
Thanks, Dale, and thank you to Sam and David as well for their excellent talks and for such a great learning experience for us all. I certainly learned a lot from that and will take a lot back from it, and I hope everyone else will as well. There's certainly a lot to be gained by reading all the documents from the World Brain Death Project, hopefully not all at once, but I think you'll find many answers to your questions within those documents. And as always, it will raise as much further discussion as it will provide answers. But thank you very much.
Thanks, everyone. And please join us next week with a promotion on regionally focused campaigns on the 27th of April, UK 11 a.m. For our next in the series of the weekly webinars, taking us all the way up to July 22nd with the inaugural ceremony for the Commonwealth Tribute to Life project. Thank you, everyone, and have a good day, evening, night, wherever you are in the world. Thanks very much.